Okay, good afternoon and welcome to the therapeutic hypothermia webinar. Today we'll be talking about therapeutic hypothermia in two different situations, both in cooling and in warming. The first half will be on the cooling side, the second half on the warming side. So I'd like the two speakers are Dr. Christina Latamuis and Dr. Kravchuks, both from the Baltic region. We'll start off with the cooling. So I'd like to begin introducing and welcoming Dr. Christina Latamuis. Dr. Christina Latamuis is a senior teaching doctor in cardiology at Tartu University Hospital and is also an invasive cardiologist at the East Talon Central Hospital. She brings extensive experience in cardiac intensive care and invasive cardiology with advanced training across Estonia, Latvia, and Finland. Her expertise spans coronary and peripheral intervention, endovascular thrombectomy, and stroke care. She is also an active researcher with numerous publications in the field. We are honored to have her share her insights today about invasive temperature management. So I'll pass it over to you. Thank you very much.
Okay, thank you, and hello and welcome to everybody. And now I'll start sharing my screen, and I hope so you see it well, yes, and you hear me.
Yes.
So this is a part of the cooling, and as you see here, there is one maybe a little bit fun. Start with a fun fact with a controlled hyperthermia, because penguins actually are doing this for survival. They are colder than the surrounding air, so with the camera. But if you go back to the controlled hypothermia and our experience with it, I understand that mostly we talk about our setting and our experience when we started. And I try to remember, but I think it was 2010 when we started, and we started immediately with cooling machine. We didn't have any like blankets or outside cooling, so we went directly. We had very few patients if the machine was in the maintenance or something, but all our patients are mostly cooled with the machine. And this is a setup or a photo from 2017 before the renovation in our unit. And you can see here one of the patient being cooled after resuscitation, or actually with a controlled hyperthermia. Why we use it? I don't talk only about our experience. I try to put a little bit like the information and then the statistics and evidence. Yeah. So we can call it also targeted temperature management, and this is a treatment that lowers body core temperature, and this is very important, that core temperature, not only surface temperature. And this is done to protect the brain and other organs from damage after period of the reduced blood flow, like after resuscitation and ROSC. This works by reducing metabolic demand, and the aim is to limit ischemic injury. And so how it works, or the mechanism, is that with every drop of the degree, we reduce not only cerebral metabolic rate, but also in other organs, free radical formation, and some inflammation response. And we use it after cardiac arrest. This is a most common indication, but also the same machine was used, of course, in our other wards after, like, I know certainly the cardiac surgeons were using, the IRs were using, and also for a warming, the same machine. And during certain, like, operation block was using also. So, but my experience is solely in cardiac intensive care. And typically it's 33 to 36 degrees. We started with 33. And about in 2015, we switched to the mixed temperatures, like some of them 33, some of them 36, 7, and I later explain how we choose the patients. The most thing or was afraid with the controlled hypothermia is risks and monitoring them. So yes, it's not just cooling down the patient, but lots of metabolic and the changes become. So they can be arrhythmic. Bradycardia is actually, you have to think that this is not a side effect. To the certain level, it's a desired effect. So you have to define, is it giving you a high lactate or like problem? Is it problematic, or is it the desired effect and that is normal? Because we see some patients are even 40, 60 beats per minute, and it's totally okay. You don't have to cut off the hypothermia. Coagulopathies are they and this is mostly a problem. So you have to monitor the patients and you have to select the patients. Electrolyte imbalance is mostly by potassium, high potassium, and infection risk is considered, but most of the patients get infection anyway, so it's a little bit hard to differentiate, because after resuscitation anyway, I have to say like 90% patients got some pulmonary infection, and then also can have other side infections. And shivering, which is always bad, but it's controllable. So a little bit about coagulopathy, because our patients are cardiac patients, so most of them go to the cath lab, they get stents, and they need to have plated medications, and they are also resuscitated, so they can have some intrinsic traumas. So we started with screening, with a CT screening before, and because we already know if we give heparins and everything, you can have lots of bleeds. But if you think over, you can understand that if you understand the mechanism of the cooling, so it's a little bit easier. So actually, this is one way. It inhibits platelet activation and aggregation, and this is temperature dependent mechanism. And in the other way, it affects coagulation enzymes. So actually, both systems are like, you have to monitor them, and you have to monitor the patient with the bleeding, but mostly by case. And the other very important theme is shivering. We monitor the shivering all the time, and not only the visual shivering when it's like very overt, but you have to look like the smaller core muscle shivering, because actually shivering can zero all the good things from the controlled hypothermia, because this is a huge demand of oxygen for all the tissues. It's you can say if the patient is shivering, it's almost the same like he's running around the hospital jogging. Some of the people say the same energy, like jogging. And what you can do a surface counterwarming. This works quite well, like some fingers and toes to warm up, and the local warming, very, very small degrees. Avoid unnecessary hypothermic overshoot, so it's not too low. It's what you don't desire, like to go 30 or 32 degrees. And normovolemia and sedation, of course, for these patients. So next steps is magnesium, and usually after that we do paracetamol. So they work also together quite well. Sometimes we need midazolam or propofol, or like the sedation, more sedation. but and usually if the patient is not cooperative with a ventilator or something, this is also happens. And I don't remember, very few patients actually need some neuromuscular blockades, but sometimes in the very beginning they can may need it, but it can mask like this seizure activity, and this is not very good for prognosis also. And we do it like step by step. We never do like all these together. Like we said, we use mostly the machine cooling and the intravascular cooling, because as you see with the extravascular cooling, most of the studies show that the temperature is not so steady. This is one problem. And because steady temperature is one very strong indicator for the better prognosis, or gives you better prognosis, so the temperature deviations, even 1 or 2 degrees, can zero all the good effects from the cooling down. So it's really important to have even temperature, and then you can achieve with intravascular cooling. So I looked up what they say now, what the management suggestions are, and actually I have to say we used in the very first days, we also used them by almost instinctively or something like this. And actually this multidisciplinary review works very well. This immediate imaging after ROSC, like I said, we do if the patient arrives to the emergency room, we go to the computer to CT to look at the bleed in the brain and in the thorax, because lots of the patients, if they are longer resuscitated, sometimes in the ground or somewhere, I don't know, at home in some places, they have been fallen. There has been cases then this information comes later. So now we do almost all patient CT, so you don't see big bleed at the beginning. And of course, a little bit balancing between this bleeding risk. Do the patient needs all the stents we put in? How the medication should go? Can I do with dual antiplatelet? And we always test our heparins. If we do low weight molecular heparin, we always test. So, and actually we didn't do below 33. I think maybe very few patients at the beginning, but mostly we started with 33. And we use for deep venous thrombosis prophylaxis, we very rarely use actually compression devices. It's possible, but we go mostly with low weight molecular heparin. And if it's some problems or persisting problems, we do very easily gastroscopy, because some patients bleed from there, or re-image CT. So not stay that if the CT is okay, like 3 days ago, it can not be later. So always reconsider. What we did, we try to choose if the patient is younger, non-bleeding, no comorbidities. We mostly started with 33, and actually we do it now also, this kind of randomization. And if there is an older, fragile patient with comorbidities, then we go for like slight hypothermia or just temperature control, not to be fever. And sometimes, as we are more Nordic country, we sometimes thought if it's arrival core temperature was very high, like it's summer, patients sometimes, or they collapse in a sauna or on a I don't know, in the sun, in the heat. And then we used lower temperatures, 33. And if the arrival core temperature is already low, like 35 degrees, the patient has been like half an hour already 35 degrees or less, then we go 36, 37 temperature control. So I don't know, does it have any evidence? Mostly it's like a common sense or our like, yes, considerations. And like I said, we mostly did CT to eliminate bleedings. And I like, if I see this ranking score, first we thought or we like considered all the statistics, and then how it's, maybe it's better to have not 6, it's good to have 4. But if you look at this screen and think about younger patient or even like older patient who's doing very well, so actually only good things are good, like here on the picture. So we started to consider that good outcome is mostly, it's should be almost the same like was previously, but actually it's less than 3. It's not so good anymore. And actually, if you already started dying, to die, it's not a worth thing to have. It's worth thing to live with a huge disability. So in the beginnings, while I'm talking about this, I found actually our quite old slides. It's 2016, and I looked. You see in the lower there is a ROSC, and you see we did quite with a quite long ROSC scale also, and we see. But actually, the ranking scale is, it's linear, but you can have different these ranking scales in different ROSCs. So these are all hypothermia patients, and now we consider if the ROSC is very long or starting to be long, we cut off, we don't go further, and we not always cool this like 40 minutes or patients. And in this 1 year, we had 16 patients, and you see, we did also asystolic patients. Now there is a small evidence and small suggestions that mostly they do shockable rhythms, but we used, and now some of the suggestions also are to use it non-shockable rhythm. So, but their outcome is not so good, as you know, and. This is a ranking scale going out from the hospital, and this is for a 2-year data, 2015-16, and you see the ROSC can be, there was even 60-minute ROSC, but of course it doesn't go well. I don't know, actually I can't comment now why there was so long ROSCs, but sometimes it's different, that like ambulance starts and then they go on. So I have to say now we are much more strict with this. And actually here we see it's quite similar distribution with different degrees, and actually with the other studies. So after this hospital, and here yes, here I wanted to show you that actually with the lower temperatures we had worse outcomes. It may be that like I said, if we choose lower temperature if there is younger, more maybe problematic or other negative risk score patient. So just to try to, maybe it helps, but maybe we should choose with more correctly the patients. And actually some other the studies also show that there is no big difference or not helping this lower temperatures. There is more, can be more problems. So one thing is like if they leave the hospital, some patients die in the months. It's actually, this is a lower bar is where they leave hospital. There is quite even distribution, and lots of patients die within the months with like especially with ranking 5 and 4. scale because they are very, very ill anyway. So that's why I said they, from the hospital, it may look quite good, but they leave, they're so ill so the day anyway. So actually this is ranking 0 to 3 is something we should aim. But how, and this is like I promised, it's almost the same distribution with, this is a 6 months, but also TTM2 trial 2021. And there is some discussion about this because they used actually lots of surface cooling. And here we see that normothermia, hypothermia are almost the same, like statistically same. But the one consideration is that they didn't use intravascular devices so much. And actually, if they look at the intravascular group, there was a little bit better prognosis inside this. So actually, we have to think how we do it. And both together, this hypothermia, normothermia, to TTM and TTM2. And again, we see that lots of patients, like half of them die, and the other is the same. So, but this is a study I little bit more promising. Here we see actually the mortality is the same. Like I said, if they die anyway. But here we see what it's the neurological outcome is much better with 33 degrees. So it's something promising point. And this was this Hyperion study, and the discussion was that this is maybe neurologically beneficial for post-cardiac arrest patients with also with non-shockable rhythm. Like I said, we also started very long time ago with some non-shockable rhythm, and here also, because they also included non-shockable rhythms. So, but and at least you should avoid fever. So, and what we do now, we do normothermia mostly. So we don't do this lower degrees so much. We do, if the doctor is allowed, or you can choose 33 if you think it may help. So again, with these younger patients, I try to do this normothermia, and of course this hypothermia control. Where we put it, we have these catheters in the cath lab actually, and we try to put the most in angiography because this is more sterile and it's more quicker also. You don't have to double cover the patient, or if we do it in a ward, we do if the angio is not done or postponed, and then we put them here. So we train our nurses. This is the most important thing because we call up and they know all these packages. You see here, they open them, they start the machine. So if we come up with a patient, everything is working already, or we can just connect. So it makes it more easy and more fluent on the and the workflow. And of course, they know how to monitor the patients. This is a very old protocol. It's in Estonia, but just to see that we had very short and simple points, what they do for a doctor, what temperatures, and for a bleeding, hemodynamics and metabolism in the blue box, they had just very simple lines to follow. So it's really easy. And we do it 12 or 24 hours, as you see in the red box bottom. So what to monitor, I think I told about this. I go a little bit further. And we always use double probe because we had some problems. So we use one from a machine and other from the patient, like nose or sometimes skin probe. So that also helps if there is some problem or the patient starts to warm up, then we see it very quickly if it's some technical problem. So always use two probes. And first, the timing was as fast as you can, but now I understand we also go this. So very fast, we had to very quick cool down, but now they say it's more stability and like you have to do it more precisely. So now it's take time and even like controlled cool down, because we used only controlled warm up like 1.5 degrees. I also show you some cases, like one case here. You see the closed, very small right coronary artery closed, but previously totally healthy patient. It's 10 years ago. Quite short resuscitation time from ventricular fibrillation, and goes angio, and you already see during the angio the catheter tip from vena femoralis here. So the catheter was placed in the cath lab, PCI done. The final picture is nice. So this is, you see small right coronary with thrombus and spasms, but later it was quite good. And the patient was interesting because we had lots of problems with delirium and actually was reintubated and tracheostomy patient during the hospital stay. It was long hospital stay over months. And he was leaving the hospital with a ranking scale 4. Like I said, it's usually like bad, or we already consider it bad. But surprisingly, and we actually all already said that maybe with a good outcome. So surprisingly, after 1 month, he was in ranking 1 and he was slight memory problems. But sadly, the patient passed away with a cancer a few years later. So one thing we see that with the hypothermia, sometimes you see very like slow responders, or they go better very slowly. So that's patient maybe. And one thing to consider is very large myocardial infarction. This is young man, large anterior STEMI, and this is in hospital cardiac arrest. Also, we did them from the beginning. We didn't choose only that only because in sometimes guidelines it was like only out hospital, but we did. And now there is some slight suggestion that you can do in hospital also. So it was quite short, but you see huge troponin leaks. It's like over 83,000. It's and the peak, and ejection fraction very small. So with a large MI, with hypothermia, there is a conflicting evidence, but the idea is to reduce the reperfusion damage, and actually it can help with other like microvascular and biochemic mechanisms. So it can be, like I said, the data is conflicting, or not all studies are showing it, but this is thing to consider if you're having a resuscitation patient and very large myocardial infarction. So we choose, was one setting to choose lower temperatures like 33 degrees, if I think previously in our center. So what the guidelines now, like Ilkor saying that, like I said, especially with a shockable rhythm out of hospital setting, but also it says in hospital cardiac arrest with any initial rhythm, and patients who remain unresponsive. And target temperatures between 33, 36. So they just give a rank. They don't say that you have to be that or that. So I think it's very very good recommendation. And American Heart Association recommendations are to update it, and they say it's reasonable that maintain temperature control at least 36 hours. It's longer. And with patients who remain unresponsive to verbal commands after OSC. And it can be hypothermic control, adjust the temperature, not not to let them to be hyperthermic. So I think I ran through my slides, and now the time for questions.
Excellent. Thank you very much for that informative talk. So two different questions. The first one is when you spoke about the results and the outcomes with patients, you were speaking about the ROSC, etc. Do you believe that and have you seen any difference of the flow time of, how long the patient has been out before they started resuscitation to see the difference? Um, and, together with that, sort of also looking at, like you said, your timing, like the early cooling, the late cooling, you said 3 to 6 hours. But in your patients, are you able to determine at all a difference of results depending on those other factors?
Actually, not with the cooling timing, because first we did it very quickly, and there is maybe a few years or few patients what we did a little bit later also, because even now we try to do it in the quite in the beginning, like I said, because we do it in the cath lab, so mostly this is one point where they get the catheter. And of course, if we go back to the no flow and so low reflow times, there is evidence that no flow before resuscitation, longer no flow, of course, it's very bad. But like you see, our patient group is quite small, and we should do it for like all these 10 years. But I think our some other things are so much changed, so we can't say. So no, we don't have the statistics now. We are a small center, but if we do look at the data, so long no flow before resuscitation, this is actually the same with the bystander. So is it the bystander resuscitation or not? So it's very important. And like you say, if this no flow is very long, and the patient, sometimes we don't start or even do this non-active therapy decision. Of course, it's always a team decision. It's not like I go and say, oh, we don't do anything anymore. But this is very long before not bystander or a very long no reflow time can be something we say that it's a very bad prognosis. And
Okay, thank you. And second question, can you explain the counter warming? What is this and when is this being executed? Are you having this part as your standard protocol?
actually, we started very long time ago. It's small evidence, but it's like a physiological process. If we you mean like a surface warming, so it takes off. It's like so it cuts off some neurological pathways, or like it foolish the brain. The brain thinks basically that the patient is warmer. And the other thing is, it's not only this cutting off this pathway, it's actually gives you in the intensive care. We know that peripheral vasospasm is very bad thing. Actually, it's reduces afterload. It's not oxygen consumption is not normal, and if we open up periphery, the patient, if you say quickly, lives better, because these two mechanisms, it's microvascular and it's also like neurological pathway, both.
Okay, thank you very much.